Everyone, so welcome to today's Thursday series, and I think Nikita is presenting today, and Professor N.P. Singh is here with us. So let's get started. Nikita, please start off your case.
Good evening, everybody. Mr. AK, 65-year-old male, resident of Delhi, retired from bank job. History given by self and his wife is a case of chronic kidney disease on maintenance hemodialysis. This came for routine hemodialysis session. I would like to start my history 20 years back when my patient was diagnosed with hypertension 20 years back in 2002 as he was experiencing headache on and off, which was holocranial in nature. When BP was checked, his BP was 160 by 100. He was started on oral medications, tablet amlodipine, tablet telmisartan, and he was taking them regularly. At that time, there was no history of any pedal edema, hematuria, frothy urine, or any oral ulcer, joint pain. There was no history of any chest pain or dyspnea. For next 8 years, he was symptomatically better. On regular visit to the doctor, his BP was in the range of 140 to 150 mm of Hg. He required increased dose of medications during this period. Blood tests done during this period were normal and urine tests were also normal, according to him. Later in 2010, he started to experience exertional dyspnea, which was associated with chest pain on exertion, relieved on rest, and this is the symptoms were there for 2 to 3 months. It was not associated with orthopnea, fever, or cough, for which coronary angiography was done in 2010, and he was told that he is having mild changes in vessels, but no major procedure or stenting done post CAG. He was started on tablet Ecosprin 75 mg. Afterwards, at that time also post procedure, his serum creatinine level was normal. He was in regular follow-up with doctor. His BP, though his BP was in the range of 150 to 160 mm of Hg. In 2016, on regular blood checkup, his creatinine was first time raised to 1.5 mg per dl. For this rise in creatinine level, he visited nephrologist. There was no history of any dysuria, hematuria, frothy urine, or passage of any stone or decrease in urine output. There was no history of any intake of over-the-counter drug use. After doing ultrasonography, he underwent a kidney biopsy. Post procedure was eventful. According to him, he was told that the changes in kidney are due to the hypertension. No specific treatment or any specific drug was given after that. For next few years, his creatinine was in rising trend. In 2018, his creatinine rose to 2 mg per dl, while in 2019 it was 2.5, and in 2020 it was 3.5 mg per dl. This rising creatinine level was associated with increase in urinary frequency at night, which he used to go around micturate around 1 to 2 times at night without any decrease in urine output. There is a history of body ache, easy fatigability. For this, he had a history of taking alternative medications in the form of powder for 2 to 3 months. In 2021, he started to experience bilateral pedal edema up to ankle for 3 months, which was gradually progressive in nature and pitting in nature. It was associated with increase in shortness of breath progressively from grade 2 to grade 3. There was no history of any chest pain, palpitation, or orthopnea. He used to pass urine approximately 1 liter per day. His BP was in the higher range, 160 by 100 mm of Hg. His serum creatinine rose to 3.5 to 4 mg per dl. His hemoglobin, as he remembers, was 7 gram %, and for this he was started on oral iron tablets, and he was added tablet furosemide also. Ultrasonography at that time done was showed that his kidneys are small in size. These symptoms increased progressively over next few months. In 2022, he experienced a decrease in the urine output. He used to go around 1 to 2 times per day, associated with increase in pedal edema. It was also associated with shortness of breath, vomiting, decreased appetite, but there was no history of any fever, loose motion, bleeding, or there was no history of any chest pain, loss of consciousness, or altered sensory. At this time, his creatinine was 8 mg per dl, and his HB was 7.8 gram %. He was started on hemodialysis for the first time through right IJV non-tunnel HD catheter. The first HD catheter, first dialysis was done for 2.5 hours with a 1 unit of blood transfusion. The next session were done for 3 hours and later on 4 hours afterwards. It was done for twice a week. There was no history of any fever, chills or chest pain, vomiting, drowsiness or altered sensorium post-dialysis. He underwent left brachiocephalic fistula, IV fistula creation during this admission, and as his vessels were not appropriate for radiocephalic AV fistula according to him. After 2 months of dialysis, the HD catheter was removed, and he was started from dialysis from the left brachiocephalic fistula. The HD was done from online machine, and the blood flow of around 250 to 300 ml per minute. He experienced during the dialysis. He is intradialytic weight gain of around 2 to 2.5 kg, and with a dry weight of around 50 kg. During the hemodialysis, his BP increased up to 180 mm of Hg in first few hours of the dialysis. At present, his urine output is around 200 ml per day. There is persistent, nausea is present. He also gives history of itching all over the body, for which he applies the emollient over the skin. Initially, he was started on injection erythropoietin, 4,000 units twice a weekly. Now it has been stopped from a few weeks, and he started on tablet desidustat 100 mg on alternate day. There is no history of any tingling sensation or any other weakness of the limb. There is no history of any travel trauma, fracture on travel trauma, or difficulty in getting up from the bed. In past history, he is non-diabetic. There is no major surgical event occurred. There is no other major surgical event done except CAG done in 2010. In personal history, sleep disturbances are present. Constipation is present, for which he takes laxatives. There is no history of any addiction. In diet, he is non-vegetarian. In diet, he includes eggs, fish once a weekly, and fruits, dal, and dahi. In family history, history of hypertension is present in mother and father at the age of around 50 years of age. There is no similar complaint in family and no history of a kidney disease in family. Patient is vaccinated for COVID by the with Covishield vaccine in March 2021, and June 2000. Second dose was given in June 2021. He has completed 3 doses of hepatitis B vaccination, and he has been advised for the kidney transplantation. Wife being the donor. During the donor evaluation of the wife has been diagnosed with hypertension, and she is on one single antihypertensive medication. Blood group of the donor and the recipient is B positive. At present, the recipient is reluctant for the transplantation, so he's continued on hemodialysis.
Right. Okay. You finished your history, or you?
So finish.
Okay. Today, my first question is, what is your diagnosis?
What is?
What is your diagnosis?
So so it is a case of primary hypertension with chronic kidney disease stage 5D on maintenance hemodialysis twice a week, access being left brachiocephalic fistula, with etiological diagnosis being hypertensive nephrosclerosis, and with coronary artery disease.
So my first question to you is, suppose if I take 100 cases of hypertension 10 years over and follow them up for 10 years, obviously all 100 will not develop end-stage renal disease, right?
Yes, sir.
What are the factors which contributes to worsening of renal functions or impacting renal functions in a patient with hypertension?
So normally around 2 to 5% of the patient progress to ESRD over a period of 15 to 20 years. And the persistent increased BP with more than 160 millimeter of mercury.
So uncontrolled blood pressure, right?
Yes, sir. Second, sir, if it is associated with other comorbidities like diabetes, obesity.
Okay.
Third, sir, if he is taking other alternative medications, like if he is taking NSAIDs, history of NSAID taking, or other nephrotoxic drug intake, or contrast.
Right. And so any other contributing nephrotoxic agents, let us say, right?
Yes, sir.
Anything else?
So if the patient is also having renovascular disease, second patient with the secondary hypertension.
होगा ना? We are talking about primary.
Yes.
So most important would be, I can't choose my father, I can choose my father-in-law. So genetics, right? Genetics contribute immensely which patient is going to develop CKD. Then my father-in-law, that is environment. In environment, I have to choose them. Obesity, sympathetic overactivity due to any cause, OSAs, smoking, all these can further contribute.
Yeah.
Them as,
Smoking, I think you should mention, we often neglect that it's a very well documented factor now in progression of kidney disease. So in your personal history, I was expecting that you would, because otherwise it's a straightforward case. You have told us the biopsy, nephrocirrhosis, it's an open and shut case. But what are why did he progress, as Professor NP Singh said? That is where the crux lies. And the other question, what is the normal rate of progression? Do you think the progression here is rapid, or what is the normal expected rate of worsening of renal function?
So seems around 2 to 5% of the patient progressed to ESRD over a period of 15 to 20 years. If the blood pressure is uncontrolled over BP is 160 by 80, 160 mm of HG.
In a particular patient, what is the annual decline in eGFR? What I'm asking, and then you say this is the average. And then, if it's faster than the average, then you try and look at factors. That's a different way of looking at it. So about anything about 3 to 4 mils per minute is what, most. And obviously, if you have any of the other risk factors, then like proteinuria, I don't know whether you mentioned or not, hypertension is obviously there, and rest we have discussed, family history.
See, Nikita.
Yes, sir.
First symptom after hypertension was breathlessness or chest pain, which was non-contributory CAD, right? So
yes, sir.
That is the first evidence that he's developing a left ventricular dysfunction, and that is the evidence that target organ disease is setting in. Creatinine being late to rise, even though his kidneys would have started to show manifestation of hypertensive nephrosis, but because his creatinine was not rising, we were not bothered. Right? So that particular time only, when the patient had a left ventricular dysfunction, that would have associated other organ involvement, target organ disease, will also make this patient towards different line as compared to a person who does not have a target organ. Okay?
Yes.
Obesity, NSAIDs, alternative drugs and medicine, non-compulsive drugs, all these are environmental factors.
Yes.
And pollution. Now we know pollution is one of the
very true
risk predictive of chronic. Those who are staying in Delhi, their decrease in GFR is much faster than those who are staying in Badusahab or Sirmaur. So the pollution is also now contributing factor. Okay.
Okay.
So all these are, you need to, as we go higher up, we need to assess our patient in a much broader way, and as Professor Dr. Gulati has said, Professor Gulati, we need to think loud, patient-centric. That why is it that he has gone into cancer? Okay, as he said, otherwise it looks, and you have done a biopsy also, and you find out it is hypertension only, right?
Yes, sir.
Proteinuria you mentioned, I missed out. I mean, did you in the history you have not you have elicited gone to great details eliciting the biopsy, serum creatinine values, but we didn't find a mention of proteinuria in the history.
I had mentioned that he did not have any history of any maturia for the urine. In history, he did not give any history of the urine.
Okay. Short of a significant proteinuria, the only condition which would have mimicked this would have been a mild IgA nephropathy.
Yeah, very true. Very true.
Cause where the hypertension, but if the patient did not have proteinuria, then
chances.
No strong indication of doing a kidney biopsy in this patient. Do you agree, Professor Gulati?
Yeah, absolutely, sir. Absolutely. Okay, one more. So you mentioned that this patient is having intradialytic hypertension, right?
Yes, sir.
Okay, so what are the causes of intradialytic hypertension?
So intradialytic, however, the most common cause is increased sodium intake and fluid intake during intradialytic period. Second, sir,
but then you have started dialysis. Why should you develop hypertension during dialysis?
Volume overload is volume overload.
No, he would have hypertension. No, he would have hypertension at home also. So you have started dialysis and the blood pressure starts worsening. So what is the cause?
Whenever there is an initial period of initial increase in dialysis, initial increase in increase in BP in initial period of dialysis, the volume overload is one of the most common complications. Second, sir, either taking
Volume
the
overload, I disagree. So volume overload will contribute to hypertension even at home. Even, he's now here's, let's say there's a patient who's coming to you with normal blood. When we talk about intradialytic hypertension, we mean a patient used to start with has got normal blood pressure, and then you started dialysis, and then his blood pressure started worsening, which I don't know what you meant, but this is what is intradialytic hypertension. And now you have to tell us what are the possible causes here.
So if he is not taking antihypertensive medication before the dialysis, or he's taking those medications which are dialysable medications.
Good. So one is if he's on antihypertensives which are dialysable.
Yes, sir.
So which are those antihypertensives?
So dialysable antihypertensive are in beta blocker. Metoprolol is one of the highest dialysable medicine.
Right.
Other are atenolol, which is partially dialysable.
Yeah.
And in ACE inhibitors, mostly 50% are dialysable. Those are 50% dialysable, except fosinopril, which is non-dialysable.
Right. That's one. Okay. So with one drug you have taken care of. What else?
Other things are if increase in sympathetic nervous system activity during the dialysis and increase in endothelins normally during the dialysis. Second are in dialyzer use.
Increase in endothelin. Just a minute. What do you mean by increased sympathetic nervous system activity during dialysis? Why should he have it only during dialysis?
So because of this, normally whenever the patient use whenever the dialyzer use is done, or the first time dialyzer is used, there's an increase in the reactions, increased chemokine and cytokine during the dialysis.
You mean that okay, I'll agree. What else?
Sir, EPO injections also causes the increase in hypertension during the dialysis. Okay. Specifically if it is given IV than subcutaneously, then hyperparathyroidism itself is one of the cause of hypertension during the dialysis.
Hypertension during the in dialysis patients is different. That's we're talking about intradialytic hypertension now.
But is there any role of sodium profiling or
So first of all, too rapid. If you ultra filter them too rapidly, so that could be one of the reasons that you have because that
any role of calcium, any role of
high calcium dialysate and high sodium dialysates are causes the intradialytic hypertension.
Yeah. So you can divide them into, as you said, first we have to ensure that there is no volume overload. Though, as Professor Gulati has said, that patient should have been better after first maximum ultrafiltration. Sympathetic overactivity is a major driver of Intra, right? Activation of renin-angiotensin. So that is why sometimes we start telmisartan on after that. Then endothelial dysfunction is a theoretical possibility. Then what are the dialysis specific factors? As you said, sodium gain, net sodium gain, high calcium, hypokalemia, then medications, and then vascular stiffness. As we grow older, our vessels become stiff. We are also stiff. And more important is that these unfortunate people who are on dialysis will have much more stiffened, arteries than aspirin. So all these factors can contribute. But you are right about all. But you need to understand that how to present your answers to an examiner is also important, right?
Okay, sir.
Itching. You mentioned itching also. Now, what are the causes of itching in a dialysis patient? So
itching. So uremic toxins are the major causes of the itching.
Yeah.
One thing is the increase in hyperparathyroidism. Other uremic toxins like the accumulation of uremic toxins in the skin. Second, there's an increase in activity of the mu receptors. So itching is now considered as a peripheral nervous system complication of the dialysis. Right. So increase in mu receptors, sensitivity to mu receptors. Right. And third is xerosis during the because in dialysis patients those are poorly nourished patients, and xerosis is one of the cause of the itching.
Okay.
And the release of histamines from the mast cells is another theoretical.
So coming to the treatment of itching, what would you do?
So initially, the proper adequate dialysis is the first step to be dialysis. proper adequate dialysis is the first step. Second, we can use the emollient, skin emollients, which
No,
will
before
decrease
that you
the
mentioned,
itching.
no, calcium, phosphorus, PTH axis, you have to be sure that everything is in order. Hyperphosphatemia is
Yes.
taken care of. Hyperparathyroidism, the secondary hyperparathyroidism.
Calcium,
You
magnesium,
said,
and
so make sure that those are optimized. Number
yes.
3 is emollients. Number
Number
4,
4, sir, antihistaminics can be given.
yeah,
And fifth, newer drugs like the kappa receptor agonist like diflectfelin or nalfuramine. These are the
yeah.
newer drugs which can be given.
And in cases of resistant itching, very bad itching, what else?
If the patient is having resistant itching and if it is associated with the hyperparathyroidism, then parathyroidectomy is the additional option which can be given. So.
Yeah. And UV light also previously has been used, in
But
treatment
it
of
is
itching.
associated with cancer. So
Yeah.
cancers.
Resistant itching, if they cannot go off to sleep, occasional patient will get.
So is there any role of gabapentin? With one drug, you can look after 2-3 drugs,
Yes, sir.
3 symptoms, right?
Yes, sir. Low dose gabapentin initially we can start with 100 milligram and then
100. Always start with. Problem with gabapentin is it is a very unpredictable drug, especially in diet. So start low and gradually increase so that the drowsiness
and
not be a problem for the patient. One problem giving rise to other problem, right? We
Yes.
must have a patient-centric approach.
yes, sir.
Now, you said vaccination, okay?
Yes, sir.
You have mentioned COVID and you have mentioned hepatitis B, right?
Yes.
Only 2.
Yes.
You didn't mean, what are the other vaccines that these patients should be getting? And
They have come up just now. COVID has come just 2 years.
yeah,
But what about other Indian Society of Nephrology?
I have asked for other vaccines also, sir.
which you didn't mention.
Sir,
Which are the other
did not,
vaccines?
sir, he did not take that. So actually, other vaccines are pneumococcal vaccines mainly.
Yeah.
Pneumococcal conjugated vaccines, and then that 23 should be taken initially 2 doses, and then later on every 5 yearly. Then yearly influenza vaccine should be taken, and other vaccines. These are the main vaccines. These are the main vaccines.
Foster?
So, zoster vaccines, a single vaccine is taken if the patient is more than 50 years of old and mainly in older patients, basically dialysis patient. Single dose is required.
Okay. Now tell me.
And children, just can I interrupt first? Let's say in children, what else would you look for? Let's say this was a child who's about, say 14 years or so. What other vaccine?
So in children, then DPV vaccines, that is diphtheria, pertussis, and
what else? Because they're planning for transplant like he is. What else? What other vaccine are you very?
So and other vaccines are HPV vaccines, HPV 16.
No, even before that, which cannot be given after transplant. So you have to give that vaccine either before transplant or you're gone after that. You cannot give it.
Varicella vaccines.
Yeah,
sure.
So child, make sure that varicella. Some of them can develop fulminant varicella, especially if they have not had exposure. So a general checklist, and in the patient like him, I would do. Often history is not available, so I would just check for varicella IgG antibodies and see if they are not there. Then even that vaccine can be looked at anyway. So or you should mention in the history that he's had chicken pox, and so that the examiner knows that you at least thought of this. Okay.
Okay.
Right. Carry on. Yes, over to Dr. Singh. Yes, please. Sir, anything else you want to, or should we proceed?
So
history of blood transfusion, did you mention?
Yes, sir.
So is there history of transfusion or not?
Yes, sir. There is a on the during the first dialysis session, he had history of one blood transfusion.
Good. If you have taken that.
Yes.
Okay. So you did mention about his creating a vascular cells, and there were some issues related to that, right?
Yes, sir.
Tell me, when is now there's a very, very controversial thing. When is an ideal time to start to advise a patient with CKD get a AV fistula made, at least to counsel the patient?
Yes.
And when should it be ready? And what percentage of Indian, I'm not talking about Western data, are ready with AV fistula when they reach end-stage disease or require dialysis?
So, according to the KDCO recommendations, the fistula should be made if the GFR is between 15 to 20, less than 15 to 20 ml per minute, or the patient.
Okay.
Or if the dialysis requirement is within 6 months of the, if we are predicting the dialysis requirement is within next 6 months, then the patient should be advised for the AV fistula creation. And in Indian
Is
settings,
there any benefit of AV fistula making earlier? Are you aware of any studies which have shown that making a AV fistula earlier may benefit? I'm just asking you a right question. This is a research in the gap in the research, but there have been few isolated studies.
Yeah, case series are there.
Yeah, which have shown that making a fistula earlier may in fact halt or decrease the progression of chronic disease. So,
Yeah.
yes, sir.
that is still a research, it's not a guideline. So we need to have this knowledge, and this you can use to convince your patients when they go into stage 5 or stage 4 that, right?
Yes, sir.
Now, what are the things which you actually should be doing before advising him to plastic surgery or other place, or you making it yourself? See, this patient's fistula failed. I think he was one.
Fistula is ongoing at present.
Haji?
Fistula is, sir, well functioning at present.
Ongoing, but I think the nephrologist failed because he is a patient who was biopsied, who was on regular follow-up, and yet he did not have a fistula by the time he connected to end stage. So we failed as a nephrology team.
Yes.
Right.
That is what is important. If you are a good nephrologist, you will have to convince your subjects who are coming to you regularly to tell them the benefits of why I should get a fistula made earlier. Tell them about alternative choices during an emergency. Tell them what complications can occur, so that majority, ideally 60% of your patients should be ready with AV fistula. This is as a nephrologist, I'm telling you that when you go in for. I used to use all my methods to convince my patients that get an AV fistula, right?
And the best way is what Professor Singh has already said, that you tell them that there are reports of the creatinine going down, and you see immediately they'll agree to you.
Yes.
Yes, there are case series where improvement in EGFR has been documented.
Yes.
All right.
And what is the prerequisite for getting an AV fistula made for a patient now, today? What test would you like to do?
So I would like to do first any physical examination. The first see the Allen's test. See the patency of the arteries, proper radial artery and ulnar artery. If the ulnar artery patency is better, then we should go ahead with the other. Then that means the radial artery can be used for the fistula. Secondly, sir.
So what is the Allen's test?
So in Allen's test, we have to compress both the radial and ulnar artery completely, and ask the patient to fist to do hand movements,
clenching of the fist,
clenching of the hand repeatedly till it branches. And first remove the ulnar pressure over the ulnar artery and see the blanching. If the blanching is persistent for more than 5 seconds, then that means the ulnar arteries are weak, or the ulnar artery is not completely patent. And if there is immediate redness present, that means the ulnar artery is better. And this again we have to do with the radial artery also. First, compress both the arteries, and then remove the pressure over the radial artery. So this is the Allen's test.
And what are the predictors of good fistula outcome? I mean, because the fistula failed here. So when we are advising a fistula, what do you do?
So we have to look for the other patient. If patient is having a severe atherosclerotic disorder, like say if he is having other.
What is the rule of 6?
Yes, sir.
Have you heard of that?
Yes, sir. In the rule of 6, sir, the vein should be of at least 6 centimeter without any branches.
6 centimeter?
Yes, sir. 6. The vein length should be of at least 6 centimeter without any.
Length you're talking about. Diameter. What is the diameter?
Yes, the diameter of the vein should be at least the diameter of the fistula after making should be at least 6 millimeter.
Yeah.
It should be at least below 6 millimeter below the skin, and after making the fistula.
I mean, not more than 6 millimeters. It should be within 6 millimeters.
Within 6 millimeter of the skin. After making the fistula, the blood flow rate it should be more than at least 600 ml per minute. and it should mature within 6 weeks.
Okay, good.
Let's
Okay, examination. Let's finish off and then we can come to the discussion.
So general examination, the patient is conscious, cooperative, with time, place, and person. He's sitting on the bed comfortably. Average weight. On anthropometry, his weight is pre-dialysis weight is 53 kg and post-dialysis weight is 51 kg. His height is 1.6 meter. BMI is 19.2 kg. Pulse is 68 per minute, regular, normal volume. All peripheral pulses were palpable. There is no radiofemoral, radioradial delay. His blood pressure is 150. Blood pressure on the right arm in supine position is 162 by 100 mm of Hg. In sitting position, it is 160 by 100 millimeter of mercury. And in standing position, again, it is 160 by 100 millimeter of mercury. In right ankle, it was 168 by 100. And in left ankle, it was 168 by 100 millimeter of mercury. Left arm avistula was present. In a respiratory rate is 16 per minute, regular. Abdominal thoracic. Temperature is 98.2 degree Fahrenheit. So bilateral feeder edema is present up to the ankle, which is pitting in nature. There's no icterus, clubbing, cyanosis, or lymphadenopathy. Pallor is present. JVP is not raised. Known neck vein fullness is not present. In skin, the right IJV scar mark, SD scar mark is present. The few scratch marks are present on abdomen. Hair is normal, nail is normal. On AV fistula examinations, left antecubital AV fistula is present in left antecubital fossa with the horizontal or transverse scar mark over it of 5 centimeter. Dilated vein can be seen and without any swelling or edema or discharge. Multiple insertion marks are seen above it. There are no dilated veins above in upper part of the chest or face. There's no discoloration in the distal part. On palpation, the thrill is palpable continuous over the AV fistula. The pulse is on pulse augmentation. There is a decrease in thrill and it is hyperpulsatile. On limb elevation test, it is collapsible. On auscultation, the bruit is heard, which is continuous in nature. On a cardiovascular examination, the apex impulse is present in left 6 intercostal space, lateral to mid-clavicular line, without any scar or dilated veins. On palpation, inspectory findings are confirmed. There are no palpable rub or pericardial or parasternal vein. On percussion, left border coincides with apex impulse and right border is retrosternal. Auscultation S1, S2 is heard, which is normal, without any murmur or additional sounds. On respiratory examination, on inspection, it is symmetric, moves with so the chest is symmetric and moves with respiration. There are no sinuses or dilated veins. On palpation, the inspectory findings are confirmed. There is no pleural rub. On percussion, a resonant note is present all over the lung pit. Liver dullness is present in right mid-clavicular line in 6 intercostal space. On auscultation, a vesicular breath sound is present without any adventitious sound. On per abdomen examination, it is scaphoid symmetric. Umbilicus is central inverted with few scratch mark over the abdomen. There is no lump or dilated veins. On palpation, it is soft, non-tender, no organomegaly present. On percussion, it is tympanic all over the abdomen. And on auscultation, normal bowel sound heard with no bruit heard. On central nervous system examination, the higher mental functions are normal. Tone, motor, and sensory. Tone is normal. Motor power is 5 by 5 in all 4 limbs. Sensory examination is normal. Reflexes were present. On fundus examination, grade 2 hypertensive retinopathy is present in bilateral eyes.
Right. So quickly sum up your findings in the history, examination, and your final diagnosis. Then we go on to investigation, doctor.
So it is a case of 65-year-old male diagnosed with hypertension 20 years back with uncontrolled blood pressure 140 to 150 mm of Hg with non-critical coronary artery disease, CAG done in 2010 with rising creatinine level from 2016 1.5 milligram per DL. Post-renal biopsy suggestive of hypertensive changes with the progressive renal disease over next 6 years with history of alternate use of medication. Initiated on dialysis twice a week in February 2022 with 1 unit of blood transfusion with access being left brachiocephalic fistula, which is well functioning. with intradialytic hypertension, with history of pruritus, vaccinated for COVID and hepatitis B, and planned for renal transplant.
Right. So, Bete, I just wanted to ask you as a postgraduate, as a fellow, now, do you do routine fundoscopic examination of the eyes? Or otherwise,
Yes.
what is the importance of ophthalmological examination in patients with end-stage disease?
So one thing, we'll get to know the other end organ damage, which
Yes. So the only way you can actually visualize the arterioles is in the fundus, in the retina, right?
Yes, sir.
So that gives you a clue about atherosclerosis, about hypertensive, hypertensive changes. Doing a biopsy, if I would have seen the fundus and seen the changes, we would have predicted more strongly. As sir has said, the mild proteinuria can occur in hypertension as well, but there was no significant proteinuria to call for it. That is one. Any other thing? What are the specific changes we observe in a patient who's in end-stage renal disease?
In our fundoscopy, sir.
In eye change.
In eyes. So in eyes, in fundoscopy, we can see for the hypertensive changes and diabetic, proliferative diabetic changes. Second, we can in infections also CMV, retinitis. These are like the CKD patients are more commonly are immunosuppressed patients, so they can have other infections, CMV, retinitis. Then second, on eyes, other xanthelasma or
anyone else can also put it in the chat box. Are there any ectopic calcification which we can see? Can we see any band keratopathy suggesting? In fact, earlier on, one of the way to differentiate between acute or chronic kidney disease when you're not sure was presence of band keratopathy. That would have give you an indication that this patient has got a significant secondary hyperparathyroidism, and this is likely to be a chronic kidney disease, right? So ectopic calcification, all these are eye changes. As a fellow, I think, appear for the exam, you can be asked any question. So you need to know what are the changes which can occur individually. What is half and half sign and why does it occur? Why should hyperpigmentation occur in one part of the nail and other not?
So half and half nail is a sign of it is present in chronic kidney ESRD patients, and it is mainly due to the low albumin levels and presence of uric toxins which are deposited in the.
What about tongue changes in the tongue? Can you?
Yes. The one thing, the tongue pallor. Second, the baldness of tongue can be present if these patients are nutritionally malnourished, and other things, ulcers on the tongues can also be present. And
it can be macroglossia. In fact, that can also be one of the manifestations of chronic kidney disease, right? There are some signs described by some of our own Indian colleagues who have described that, right? So you're planning for a transplant, right? My simple question to you is: 70-year-old gentleman comes to you and asks you, he's in end-stage renal disease. What options do I have? What options you will explain to the patient?
So the 70-year-old patient with the end-stage renal disease. So I would like to give the options of transplant and dialysis. There are two main options with the transplant and dialysis. One is if the patient is for transplant also age is not there is no upper limit of age, so the patient can also go for kidney transplantation. So, second, sir, in dialysis. So in dialysis, there are two. I would like to give him the options of hemodialysis and peritoneal dialysis both. If it is according to the patient's patient choice, the hemodialysis or peritoneal dialysis can be taken.
So what is the fourth modality? That is what I am asking you. See, please understand that we have to talk to the patient. We have to talk about what are his choices. This is your choice which you are trying to impose upon the subject, right? We need to, when the decision to provide a renal replacement therapy is made, we should be able to offer them all the choices, including what do you feel do you want your life to be. That's very important. Okay. So nowadays, there are many more studies and focuses on patient-centric approach.
Yes, sir.
So my next question to you would be, what are the common patient-centric symptoms which these patients do tell us when we provide them with maintenance hemodialysis? Okay. So first question is the fourth choice. That is very important.
So in the hemodialysis, in the fourth choice is not to, if the patient is not ready for any hemodialysis or kidney or transplantation, then conservative management is another option.
Right. We have to look into various factors: his financial status, his socioeconomic status, his family care, his caregivers. All these factors do come into account, and the patient's own choice. Okay.
Yes, sir.
You need to mention. You stopped at that. That is why I asked you. Even without asking, you should mention the fourth choice. And
what are the outcomes?
And the outcomes,
hemodialysis,
yes.
What are the survival in hemodialysis versus transplant? Like you said, you would offer transplant. So the next patient, the patient is inquired, what are the outcomes on if he decides to continue dialysis, and what is the outcome in transplant?
So in a transplant, so 1 year survival is around 1 year survival is around 97%, and while in 10 year survival is around 80%. So
80?
Yes, sir. 80.
60. 5 years is 80, 10 years is 65.
5 year is 80 and 10 year is 60.
Yeah.
मैंने कहा आपका तो सेंटर कमाल ही कर गया.
5 year is 80.
Okay.
And sir, in hemodialysis, sir, now the 1 year survival, if the patient, it depends. Hemodialysis survival depends mainly on the axis. If the patient is having the tunnel catheter, then the survival is less compared to the patient is having the AV fistula. Then it is mainly 1 year survival. So 1 year survival is around more than 90%, sir, in dialysis patient, and 5 year survival. So I don't remember the 5 year survival.
No, even 1 year is not 90, 70 to 75. And 5 years is close to 20 to 30% in the best of centers. 30, never more than 30. So even in the US data. Okay, now this patient, you mentioned a blood pressure of 160 by 100, right? So what is an optimal blood pressure for a patient on dialysis?
So, so at present, so according to latest KDIGO guidelines, standard blood pressure, so standard office blood pressure should be less than 120 systolic, sir.
Dialysis? No. Stage 5 CKD patients on dialysis, it is not 120 at all.
It is like in dialysis.
You need to talk about which blood pressure reading. Is it dialytic? Is it home blood pressure? Is it intradialytic? What blood pressure reading and what?
So in home dialysis, so home blood pressure, it should be between the 130 to 139 systolic and 80 to 89 diastolic BP. And sir, intradialytic, I don't know.
You see, KDIGO I thought was previously 150 is what 140 to 150 they had mentioned, if I remember it correctly. But yes, you can see that. Now, which is the antihypertensive of choice in your dialysis patients?
So
if I have to ask you one drug to be added, which one will you add?
So ACE inhibitors and ARBs, these are the first drug of choice.
What is the DOP study? What was the outcome? Tell us about the DOP study. The best outcome was with still beta blockers, followed by ACE inhibitors. So the only place where beta blockers have a value in today's, where they've retained their value is more because why? What is the reason? What is the logic behind using beta blockers in these patients?
So they decreases the sympathetic nervous system activity.
Because because one of the commonest cause of mortality in these patients is cardiac mortality. A lot of them have atherosclerotic cardiovascular disease, ASCVD, ischemic heart disease is there. That's the reason. Yeah, somebody's already mentioned in the chat box. Good. So that's why beta blockers are a drug of first choice, and they found that the best outcomes in the DOP study were those patients who had beta blockers followed by ACE inhibitors or ARB. So yes, okay.
So Dr. did talk about drugs. I would say if you are a good nephrologist, the patient on hemodialysis may not require antihypertensive. Why do I say so? And what will you aim at What will you aim at? Am I right? Is the statement okay?
Yes, sir. So preservation of residual renal function is the one thing which we should.
So that was my next question. Anyway, I was going to ask you.
No, not using. Are there any case series available of patients on dialysis who don't require any antihypertensive?
Yes,
No
yes, I'll
phosphate
come to
binder?
that. I had a long discussion with Dr. Rajiv Agarwal, who's an expert on that. 90% of the patients, if they are volume controlled, if they are
Ah,
the issue is that we do not know how to know the right dry weight, right? We chase weight gain, we chase the weight gain, but chasing the weight gain may not be answered. We have to know exactly what should be the ideal body dry weight. Once we achieve that dry weight, then majority of the patients, because most of the times it is volume mediated, the hypertension and dialysis among end-stage renal disease, volume mediated. Yes, then there is a role of antihypertensive. The patient has a increased sympathetic overactivity or high renin levels, then we can give carvedilol is a very good drug, and as sir has said, that beta blockers. But how do you assess the dry weight? That is my question to you.
So
What did you think about a 200 ml of urine output in a patient of end-stage disease? Now that's again very, very crucial thing for us.
yes, sir. So as for assessment of dry weight, first we have to ask the history of the patient, whether the patient is symptomatic or the patient is having any breathlessness, edema, or patient is having hypertensive episodes. And secondly, secondly, sir, in physical examination, we should look for any rise in JVP or rise in JVP, even crackers or crackers in the respiratory system or pedal edema. Then third, sir, we can assess the dry weight by other newer modalities like in ultrasonography, like focus. In this, we can see the patient is, even if not symptomatic, then we can look for B lines which are present in the lungs, which is a sign of extracellular fluid overload. Then,
so point of the care ultrasound is one of very good modality, right?
Yes, sir.
Diameter is another good modality where we can find out whether the patient is okay.
Yes.
So there are symptoms. We say you keep on ultrafiltering till the patient develops cramps.
Yes.
Once
not hypotension, yeah.
cramps, then that is the right dry weight. But anyway, these are important things. We are not able to achieve that. Most of our patients are mildly over. They will go to a function, they will go somewhere else, and then they will volume overload, and then again they will go into hypertension. The circle continues. Now, what is your views about 200 ml of urine output in a patient who is in end-stage renal disease?
So if the patient is having 200 ml of urine output in his, so there's a renal residual function is present, which residual is around, yes, residual renal function is present, which is around more than 2 ml per minute. And we have to preserve that. Patient should be we can start him on diuretics. Second, with other renoprotective drugs like ACE inhibitors or ARBs, and the newer drugs like mineralocorticoid receptor antagonists.
So now coming to this, okay, which center in the world has got the best outcomes for dialysis and why? Are you aware of it? Taussig, have you heard Taussig in France? And why do they have such good outcome? None of the patients is on antihypertensive, none are daily dialysis.
Yes, daily dialysis. They do daily dialysis.
Daily 8 hours of dialysis, and they actually give phosphate supplements to their patients. So,
yes,
as Professor N.P. Singh was hinted, it's all volume driven. That this single center case series provides, very good evidence that.
Yes, yes.
Taussig in France has got the.
Now tell me. Sorry. Tell me something about online filtration. Now, what is
not opting for transplant? Would you advise HDF or would you advise hemodialysis?
Sir, I would like to advise hemodiafiltration, sir.
Why?
So hemodiafiltration has shown it decreases the intradialytic hypotension, episodes of intradialytic hypotension. Secondly, it preserves the renal residual functions. Third, sir, it has been shown that it decreased in inflammation and better phosphate clearance and better to micronutrient clearance. Though it did not show any mortality benefit or effect on anemia or the effect on requirement of dose of ESA or the anemia.
So
Yeah,
you
no
have
mortality
again to give an answer in the best way. Suppose you have two type of patients. One is a young patient awaiting transplant. He has all these issues, that then hemodiafiltration would be an ideal choice. An elderly person, 70-year-old, does not want to go into any other modality. I don't think hemodiafiltration will benefit him. Okay? Patient-centric, and as you yourself said, there's no mortality benefit.
Yes, sir.
And it's a costly modality.
Yes. Because the patient has a intradialytic hypertension and has history of coronary artery disease.
Professor Gulati, you want to conclude, or you want to?
So just quickly, now we have. What are the investigations that you will ask for in this patient, in a patient like this, to optimize his or monitor him regularly? What would be?
So in this patient, we will regularly monitor his hemoglobin level, CPC level. Then second, sir, I would like to see his serum albumin level and serum cholesterol level. Then, sir, other
Cholesterol
we
level.
have.
Okay, let's just wait a minute. Now, cholesterol level. Is there any evidence that if you use statins in dialysis patients, it improves mortality? And what do the KDIGO guidelines tell us?
There is in dialysis patients, statins are not, if they are not started previously, then it is not recommended to start the statins. But if the patient is already on statin before the dialysis, then we can continue the statins. Then,
so you want to monitor the cholesterol level. Why do you want to do that?
So there's this patient. This is mainly, sir. As such, the monitoring is not required, but mainly, sir, if for to see the nutritional effect.
Yeah.
The patient is
If
having low cholesterol.
low cholesterol has got a poorer outcome. Yeah,
yes.
Good. Right. Okay. Carry on.
The others are every 3 to 6 monthly. So his other calcium phosphate and calcium phosphate level, and every 3 to 6 monthly, I would like to check his intact PTH levels.
So what are your target PTH levels?
So target PTH levels should be within the range of 2 to 9 times the upper limit of normal, or it should be less than at least 600 milligram per deciliter.
Milligrams. I think picogram. What is the units are not milligram at all. Check the units anyway. It's not definitely not milligram. What else?
Others are this patient is going for a. Then, sir, I will regularly check his HbS, Hg, and HCV status every yearly. And as this patient is going for a transplant, then the blood group is a blood group status.
No, he's not going in for. You said no, he's not ready for transplant. So, anti-HbS levels, to make sure your antibody levels, your vaccination is appropriate.
Yeah, just giving the vaccine will not suffice.
Yeah.
To measure, monitor their antibodies.
Anti-HbS.
What percentage of patients seroconvert or show protective antibodies when they receive a standard dose of vaccination in ESRD?
Not sure, 10 to 15%.
10 तो बहुत कम है बेटे.
Not sure, sir.
It's around 30 to 60% based on studies. Then what are the adjuncts we can use? What are the methods which we can try to enhance the antibody levels?
So we can give the higher, we normally give the higher doses of the.
Yes, one is the higher dose, very good. So we generally recommend 40 micrograms.
40, yes, sir.
0, 1, 2, and frequent intervals, 0, 1, 2, and 6 months.
0, 1, 2, 6 months, and then booster dose every.
Any role of intradermal, any role of adjuncts, GM-CSF, various studies which have shown what all they have tried to enhance the efficacy. That's a difficult question, but we need to.
So the GM-CSF can be used to increase the activity, to increase the antibodies. It can be given before, it can be given after giving the vaccines.
You mentioned about you're using desidustat. So how does desidustat act in anemia of CKD?
So desidustat is HIF, hypoxia-inducible factor prolyl hydroxylase inhibitor. So it is a HIF stabilizer mainly. So it increases the endogenous erythropoietin production. So this this inhibits the HIF2 alpha degradation, which is normally happens whenever there is a which normally happens by the proline hydroxylase enzyme. So this HIF also decreases the hepcidin level, which will increase the absorption of the iron from the stomach or from the gut, and ultimately this will lead to increased erythropoiesis, increased erythropoietin endogenous production, and increase precursor of the erythropoiesis.
So,
Uh,
sir, sorry, sir. Yeah, please carry on.
you did mention one of the very important complication in patients with CKD is, renal osteoporosis. Now we call it some different name. What do we call it as? And how do we address the issue of osteoporosis in them? Do we leave them like that, or do you think we have certain choices in patients with end-stage renal disease? And what are the other associated issues associated with those choices?
So adynamic bone disease, this comes under category of the adynamic bone disease.
No, I said CKD MBD. Now we call it as chronic kidney disease, metabolic renal disease.
Yes, sir.
One of the important component of that is osteoporosis. I did not say adynamic.
Yes, sir. Okay.
How do we address that issue?
How do you assess? How do you
In case
diagnose
of
these patients?
So in osteoporosis patient, they do in history wise, they do have history of recurrent
Diagnosis.
The
Diagnosis.
DEXA scan
Okay.
can be done, that will give us the diagnosis of the osteoporosis. And in this patient, we can either
What do you
CKD.
look for in the DEXA scan?
So so we look for the Z score and T score. If the Z score is less than minus 2.5, then it is osteoporotic.
Okay, yeah.
Okay.
And so in this treatment approach, sir, we have to see for the calcium phosphorus and PTH level. And if the patient is not hypocalcemic and hyperphosphatemia is present and hyperparathyroidism is present, then we can give him the denosumab or the denosumab, which is anti-rankle antibody, which is given in the dose of 30 milliliter, initially in the dose of 30 milligram day, 60 milligram, and every 6 monthly we can give it, and till the lifelong also. But the complication of this is mainly hypocalcemia. We have to check for hypocalcemia, and patient serum calcium level should not be less than 8.4 milligram per day.
Severe persistent hypocalcemia can occur.
Yes, sir.
So we need to be very vigilant and careful. As we said, do no harm, right?
Yes, sir.
So what are the fracture risk in them? And if suppose they develop fracture, how will you address it?
So fracture risk in this is less than bisphosphonates, sir, normally, as we see in a denosumab studies. And
so now one very important thing is, you have a patient with end-stage renal disease. He is fine, he went home, and suddenly he's brought back with altered sensorium. He forget that he can, and suddenly the guy has become unconscious. What will you suspect and how will you test?
so first, if the patient has already, we have to see for the BP, see for the any cardiac. If the patient is unconscious, then we have to see for the any cardiac event has occurred, any cardioembolic stroke or cardiovascular cerebrovascular accidents has occurred. And secondly, sir, other things are dialysis disequilibrium syndrome, which can be present if the dialysis is done in the first time.
That is always with the first or second dialysis, right?
Yes.
Dialysis disequilibrium will not come they will not come with this after 1 year of dialysis, okay?
No, sir. No, not in the. Then, so other things, arrhythmias, cardiac arrhythmias, sudden cardiac arrhythmias, and sudden cardiac death can occur in dialysis patients.
So, but we need to, whenever a question is asked to you, you need to talk about an approach. I will check his sugar, I will check his calcium, I will also do a detailed neurological examination to see whether he's developed a stroke. If he develop a stroke, I would like to know whether it's an atheroembolic stroke or an intracranial bleed, which may occur in a patient on hemodialysis. Okay? And then you say whether there are some other things which happen. Okay? Intracranial bleed bhi to ho sakta hai. It can occur. Okay? But you have done excellent, marvelous. I'm very happy that you are well read and very well presented. So I am exhausted of all the questions, but there are so many.
Yeah, you've done really well. And
But
just
she's
minor
done
issues we have already pointed out over the vaccination and all. Just to remember that nutrition
those are must know. These are must know. That
nutrition is another thing you should mention in greater
very
detail.
important.
How much of calories and proteins he's taking. I mean, that we lost over because of constraints of time, but that's a very important part. Nutritional assessment in dialysis. How do you do that?
Tell us something about that. Have you ever assessed nutrition in your patients? That is my first question.
So clinically, sir, we do bioimpedance test, sir. So for testing the nutrition, we do bioimpedance test, sir.
Now, which is the optimal way to assess nutrition in these patients? What do you do?
So see for the height, weight, BMI. So see for the height, weight, BMI. See for the mid-arm circumference or a skin fold thickness.
SGA. Have you heard of SGA? What is SGA?
BMI कहाँ काम करेगा? BMI तो हर रोज वो volume
it's absolutely fallacious in this.
Fallacious
Subjective global assessment. What is that? What is that?
That is the most
It is
important.
it is a questionnaire of the with the 7 points, and we have to ask according to that.
So that has been validated in a lot of studies, and that has been found. Then you can do your mid-arm circumference now, subject to flow. Okay, right? Okay, good.
So the last question was, I asked you earlier also, what are the patient-centric symptoms? What are the patients on hemodialysis complain of? According to them, what are their major issues?
So if post-dialysis
should be filled by all the fellows. You should go back, take that performer from the net and ask your patients, what are your 10 important issues which we can answer them, right?
So major first, sir, fatigability is the most common.
I get tired. I'm so fatigued. I'm not. That is one important thing.
Muscle cramps, vomiting, nausea, decreased oral intake, anorexia. These are the most common symptoms which are present.
वो तो adequate dialysis से हो जाएगा. Insomnia, itching,
yes,
depression. They feel bad. They feel that you talk to them, you'll find that almost 90% of them are depressed. Okay. So tomorrow onwards, you must ask your subjects, what are your views on this dialysis? Okay. That's important, patient-centric.
And last but not the least, you should also read about exercise on dialysis and
rehabilitation
advantages. Again, time is short, so which of the studies have come out now that
so many studies have shown rehabilitation is they do exercise, they play everything, but you need to take them out of. Indian patients are not used to. They feel that they are already sort of gone. 3 days they are spending on dialysis, and rest of the 3 days they sit at home and that's not do anything. So rehabilitation is again very, very. Professor Gulati, this was, I think, one of the most important message which we could have given them. Rehabilitate your patients.
Right. So I think we have overshot our time, but it was an interesting, very good presentation. Thank you, Professor N.P. Singh, as usual. Really honored to have you here.
Thank you, sir.
Thank you. Okay. Bye-bye.
Thank you so much, faculty.